Saskatoon PT.
Today we're going to be talking about movement of the upper cervical region. There are three primary bones associated with the upper cervical region: the occipital bone, the atlas, also known as the C1, and the axis, also known as the C2. The first bone we will talk about is the occipital bone. The bottom of the occipital bone is involved in the upper cervical movement. There are two large convex condyles located bilaterally. They are angled anterior-medially on the posterior part of the occipital bone. The second bone we will talk about is the atlas. There are two parts that we are going to be talking about in today's lecture. The first is the anterior arch. Posterior to the anterior arch is a central articular facet for the dens. The second component are the lateral masses, which are kidney-shaped. They are two superior facets and are slightly concave and angled anterior-medially. These superior facets articulate with the two condyles of the occiput. The third bone is the axis. When examining the axis, the most notable feature is the odontoid process, also referred to as the dens. The anterior aspect of the dens articulates with the atlas, and the posterior aspect of the dens presses against the transverse ligament. In summary to bone structures, there are three bones involved in the upper cervical movement: the occipital, which articulates with the atlas to create the C1-C0 joint, and lastly, the axis, which is inferior to the atlas and articulates with the atlas to create the C1-C2 joint. In addition to the bones, there are several ligaments in the upper cervical region that contribute to the stability of the joints. For the purpose of this video, we will focus on two main ligaments and how they contribute to the movement of C0-C1 and C1-C2 joints. These ligaments are the alar ligaments and the transverse ligaments. As we can see, here are the two alar ligaments that are bilateral. They attach from the dens to the foramen magnum on the occiput. The second ligament of importance is the transverse ligament. The transverse ligament connects from the atlas with the dens of the axis. The transverse ligament prevents anterior translation of C1 on C2, thus protecting the spinal cord from the dens. As we see, it wraps around the dens from the atlas, just as so. In our video, we are going to discuss some of the muscle groups that are involved with the upper cervical movement for extension and flexion. There are three relevant pairs of extensor muscles that are involved with the movement of the upper cervical region extension movement. These muscles include the rectus capitis posterior minor muscle that attaches from the arch of the atlas to the occiput, the rectus capitis posterior major muscle that attaches from the C2 spinous process of the occipital bone, and the superior oblique capitis muscle that attaches from the lateral side of the atlas to the lateral side of the occipital bone. These three pairs of muscles are located on the posterior aspect of the spine. When working together, they create a line of pull that creates a chin poke action. Using a visual diagram, we can see the oblique capitis superior muscle, the rectus capitis posterior major muscle, and the rectus capitis posterior minor muscle. There are two pairs of flexors involved with the flexion movement of the upper cervical region. They are found on the anterior side of the body, so their line creates a flexion or a chin tuck. One pair of these muscles is the rectus capitis anterior muscle, which attaches from the atlas to the occipital bone. The other is the longus capitis muscle, which attaches from the transverse processes of C3 to C6 to the occipital bone. Here we have a visual of the two flexors that are on the anterior part of the body. The first is the rectus capitis anterior muscle. The second pair of muscles is the longus capitis.
So the first joint in the neck we're going to talk about is the C0 to C1 joint. This joint incorporates both the occipital bone in the skull and the atlas of the neck, which is the first vertebrae in the spinal column. On the occipital bone, we have two convex structures called the occipital condyles. These are convex in nature, so we will consider the occipital bone to be the male surface in this discussion. For the atlas, the articular facets are considered concave, so they are female surfaces. So the atlanto-occipital joint has 2 degrees of freedom: flexion, extension, and then side flexion coupled with rotation, giving us a coupled movement. The capsular pattern for this joint is that they are equally limited in both extension and then side flexion. So the first movement we're going to talk about today is flexion, and the other is going to be extension. This movement has rotates around a transverse axis, and it is considered to move in the sagittal plane. Okay, now next we have side flexion coupled with rotation. This movement is important as it is a coupled movement, meaning we have both side flexion and rotation incorporated into the movement. So this movement is in reference to the occipital bone moving with side flexion and rotation. And then next we'll get into the arthrokinematics. So the arthrokinematics of flexion and extension are quite simple. So since we have a convex bone moving on a concave surface, we can say that the bone moves illogically. So even though the skull is moving forward and backwards with extension, the condyles themselves inside the joint, which is what incorporates arthrokinematics, are actually moving in the opposite direction. So with flexion, the occipital condyles are actually going to be moving posteriorly, and with extension, the occipital condyles will actually be moving anteriorly. So for the arthrokinematics of side flexion coupled with rotation are a bit more complicated. So with side flexion, obviously the bone is going to moving side to side, but this time within the joints are actually going to experience a opposite translation towards the side flexion, and then coupled with the rotation, the occipital condyles are going to move in a different way. So when we side flex, we see a translation of the atlas in the opposite direction, but then when we rotate, the side that we are rotating on is going to be moving anteriorly, and then on the opposite side of the rotation, the condyles are going to be moving posteriorly. So if you're rotating to the right, this condyle is going to be moving anteriorly, and the opposite one is going to be moving posteriorly.
So here we have flexion, which has around 3.5 degrees of movement, extension, which has around 21 degrees of movement, and then right side flexion and left side flexion, which have around 5.5. And then coupled with our rotations, we have around an average of 7. So with our coupled movement with side flexion and rotation, we are going to see the head moving about a vertical axis that's just in front of the foramen magnum. And it's going to be a multiplanar movement because we're coupling the movement with side flexion and rotation.
So one typical movement dysfunction that you see in the atlanto-occipital joint is myofascial hypomobility. So this typically occurs in sedentary activities, such as driving, playing video games, or spending a long time at your computer. Because what happens is, oftentimes in these activities, you develop a kyphotic posture. And in order for your head to compensate, you have to overactivate your neck extensor muscles. So what happens is, these muscles on the posterior side of the atlanto-occipital joint become hyperactive, creating that chin poke, and as a result, the neck flexor muscles on the anterior side of the atlanto-occipital joint become lengthened. So since we're dealing with myofascial hypomobility, the arthrokinematics of the joint are going to appear normal because the movement issue is not inside the joint. The movement, the most limited aspect is going to be the osteokinematics. So what we're going to see normal side flexion, and we're going to see normal rotation. But because of what I talked about earlier, we're going to see that osteokinematically, there's going to be excessive extension, and there's going to be limited flexion. So the clinical presentation of myofascial hypomobility will appear as so. The client is going to come in with excessive extension, also known as a chin poke. So when we perform the active movements, so I'm going to ask Regan to come into neutral, and I'll adjust him as so. I'm going to ask Regan to poke his chin forward. All right, Regan, poke your chin forward. You'll notice that he has an excessive extension. Now, if we bring him back into that neutral position, and I ask him to make a double chin, or perform flexion, all right, Regan, make that double chin, you will see that his flexion is a little bit limited. Now, what's going to happen in passive overpressure is this. So when I apply passive overpressure into extension, Regan's going to experience some pain due to those strained, hyperactive neck extensor muscles. Now, when I apply passive overpressure into flexion, I'm going to meet resistance because those extensor muscles that we talked about previously are really tight, which is preventing Regan from going into more flexion. So what we're going to find with the resistant movement test is the following. So we're going to have normal strength in side flexion and normal strength with rotation. However, when I assess resisted flexion, what we're going to find is that Regan is going to be weaker. Now, when I do the resisted testing for the extensors, we're going to find that Regan is going to experience pain.
All right, now we're going to start or move on to the C1, C2 joint. This joint has 2 degrees of freedom. The first degree of freedom is flexion and extension, but it should be noted that the amount of flexion in the C1, C2 joint is fairly minimal at approximately 10 degrees. That is because the majority of the upper cervical flexion and extension occurs at the C0, C1 junction. The second degree of freedom is side flexion coupled with rotation, which provides the majority of rotation in the upper cervical spine. So, like I said, the first degree of freedom was flexion and extension. So, in flexion, it occurs, or the movement occurs about the transverse or coronal axis in the sagittal plane. The osteokinematics is where the atlas, or C1, rocks forward with the head. The arthrokinematics is where the inferior facets of the atlas glides anteriorly and inferiorly. So, second part is extension, and the axis is the same as flexion, so as a reminder, it occurs in the transverse or coronal axis in the sagittal plane. The osteokinematics is where the atlas rocks backwards this time with the head, and the arthrokinematics is where the inferior facets of the atlas glides posteriorly and inferiorly. So now I'm going to show you on a model the 2 actions, flexion and extension. That was flexion, and this is extension. And we want to appreciate the glides.
Like Regan previously mentioned, there are 2 degrees of freedom with the C1, C2 joint. The second degrees of freedom is going to be side flexion coupled with rotation. So what that means is that whenever we have side flexion, we're likely going to see contralateral rotation. The axis of movement for the second degrees of freedom is going to be directly through the nose. Because we have 2 motions happening here, it's a multi-planar movement. Now moving on to kinematics. If we think we're side flexing to the right, we're going to have a contralateral rotation to the left of C1. And when we side flex to the right, we're going to be making the left alar ligament taut or tight. So now looking at the arthrokinematics, so what's happening within the joint. If we use that same example, so thinking we're side flexing to the right, when we side flex to the right, we're going to have a translation of that C1 vertebrae also going to the right. We are also going to have a tiny inferior glide of the atlas at the median joint. And what this does is it puts a little bit of slack on the alar ligament so that we can have excess movement, or a little more movement than normal. Now looking purely at the arthrokinematics of rotation as they pertain to the facet joints, we'll go through a quick example. So if we were to rotate the C1 to the right, we are going to see the right inferior facet of C1 glide posteriorly. In turn, that will mean the left inferior facet of C1 will be gliding anteriorly.
Side flexion coupled with rotation. With a right rotation, we see that inferior facet of C1 gliding posterior, and we see that left inferior facet of C1 gliding anterior. So with right side flexion and that coupled rotation, from an arthrokinematic perspective, we're going to see a translation of C1 on C2 to the right. So right side flexion, and you can see we see that gentle translation over to the right.